So, moving forward, we need to consider some of the contraindications to regional anesthesia. When you're thinking about your patient and you are assuming that they would like an epidural or you know that they need a spinal, those types of things, things you definitely need to pay attention to as far as their electronic health record, you always need to pay attention to their hemoglobin, hematocrit, as well as platelets. So when that nurse anesthetist or anesthesiologist comes in, I can promise you that those will be a couple of questions that they're going to ask. They're also going to ask about any anticoagulant therapy or bleeding disorder because it's going to be really important if they do have like the factor 5 and she's been on sub-Q heparin or the low molecular weight Lovenox. Those are going to be things that are going to be really important to know. As far as any allergies to medication, obviously that's going to be a contraindication. It's going to be important to talk to her about the risks, and there's always a risk of infection, but if she has an infection at the particular site of injection, lower back tattoos sometimes can inhibit regional anesthesia, but we are not seeing that as a big factor. I would say they typically will look at that, and then if they can avoid the low back tattoo, they will. But most oftentimes, anesthesia will just be administered directly through that. When we're thinking about general anesthesia, it's not a good idea to use this for a vaginal birth. We are only going to use general anesthesia in worst case scenario, so sort of life or death situations when your baby is severely bradycardic or has a prolonged deceleration. We don't want to use that because the medication does cross that placenta barrier, and what will happen is that you will then deliver a very sleepy baby. So make sure that you have Narcan available to administer. And typically, what you're going to see happening between a routine C-section and a C-section done with general anesthesia is that it's going to be very quick. It's going to move like almost, you won't even believe how fast it will move. Typically, we want to have that baby out within 5 minutes, so they're not going to take a lot of time and care when they are cutting down and getting ready to deliver the baby. There's more information on page 415 of your textbook. Some of the disadvantages listed out here, obviously mom won't be awake during the birth, and so that can kind of be troublesome. She'll be set up for aspiration, especially if she's had something to eat or drink prior to heading back to surgery. So the medications we would like to use to reduce gastric acidity are going to be Bicitra, which is typically 30 cc's PO preoperatively, and then we can also use IV Reglan because the Reglan will increase gastric emptying time. So those are going to be a couple of things. Integument might also be used, or a Zantac type medication. And then again, that newborn might have some respiratory distress, so make sure you have your Narcan available. So drugs commonly utilized during labor and delivery. You know, we don't have a lot of choices available. Most everything is going to cross the placenta barrier. So really the thing we need to think about when we're considering drugs is the timing of that. So we want to make sure that we administer that medication at the appropriate time. Prior to her becoming about 4 centimeters dilated, we're going to use IV therapy. So using IV Nubane with some IM Phenergan, that's going to be a possibility. We can use fentanyl, about 50 micrograms IV. Those are really going to be about the two medications that you're going to see utilized. You may see the medication Stadol out there as well, but those are really probably the main 3 medications that you're going to be seeing. We need to think about how it's going to affect the mom. So always when we're giving a narcotic analgesic, it's going to has that potential to cause respiratory depression. We would like to know what type of herbal medications she's been taking, especially if she's taking some of the medications that might alter her blood pressure, such as your amphetamines, dietary pills. Paying attention to those types of things, always assessing for allergic reaction. Once she has had her intrathecal, epidural, spinal, those types of things, we do want to assess her vital signs relatively frequently, especially within that first hour. So I would suggest, and probably you're going to need to go back to policy and procedure of the facility that you're in. But typically what you'd like to see happening is that you would like to have vitals every 5 minutes for 3. And if those are stable, then you can move to every 15 minutes. If they're not stable, then you're going to continue with every 5 minutes until she becomes stable. When you're administering IV medication, remember that does cross the placenta barrier. So when you are looking at that fetus, be expectant that you will probably see a decrease in variability, maybe a lowering baseline, but then after the medication has been metabolized out, then you should see those returning to baseline. Maintain for safety of the delivering mom. So once she's had the epidural placed, it's important that she not get out of bed by herself. We want to turn her at least every 2 hours, if not hourly, because in turning her, it's going to help the delivery process. It's going to put different pressure on the cervix in different places. So even having her rotate, having her high Fowlers, if your bed has the ability to form into like a birthing chair, those are going to be really good. And then we want to prevent hypotension, especially supine hypotension. So we do not want her laying on her back. With supine hypotension, really the best way for a mom is on her left side, but we will go left to right and then high Fowlers. And then always going back and assessing for response to the medication. So hopefully her pain has been relieved, and usually it takes probably 10 to 15 minutes maximum for the mom to at least start feeling relief, and then full effects within probably 15 to 20 minutes. So your responsibility prior to the administration of analgesia anesthesia is obviously to obtain that consent. You want to make sure that you educate her as far as the procedure itself. When your anesthesiologist comes in, he or she will also discuss with the patient benefits, risks, contraindications, those types of things. Always ensure that she calls for help and she stays in bed after administration. We want to ensure appropriate amount of IV fluid is infused. And when I say that, anyone or any pregnant woman that is going to be having an epidural or spinal anesthetic, you should at least infuse a liter of LR or NS preoperatively or pre-procedurally, and that will help prevent some hypotension once that block is placed. If a general anesthetic is used, make sure we're using those preoperative medications that I discussed in the previous slide. Position her appropriately. Some anesthesiologists will have her lying on her side, kind of curled up in the fetal position. Others will have her sitting up at the edge of the bed, maybe with her feet on a chair. They also have stools that they can utilize, so many different things. Always monitoring those vital signs. Getting equipment for the sterile field. So when your anesthesiologist asks for assistance, you want to make sure that you're there and able to help. And then stay with the patient for a period of time once that is placed. And that's to watch her for hypotension, tachycardia, any adverse reactions. When we're talking about induction of labor, that's going to be the chemical or mechanical irritation to stimulate uterine contractions before their spontaneous onset. So if you look at page 504 of your textbook, inducing labor is one way, is really the only way we're going to be able to have delivery of a fetus unless we would move to C-section. But oftentimes with induction of labor, it's going to be using those medications that you've talked about in clinical, that we've talked about in the classroom. So using Pitocin, using Cytotec, Cervidil, Foley balloons, stretching of the cervix, stripping of membranes. So it's using something to either irritate the cervix or a medication to create contractions so that we induce labor. Augmentation of labor is going to be utilized if you have a woman that is having irregular uterine contractions or maybe a dysfunctional labor. We're going to just increase the odds of favorable outcomes by maybe adding some Pitocin. But when we use augmentation, we're going to use lower doses of Pitocin because she's already having uterine contractions, and so we just want to increase what she is already having. Contraindications. Elective indications are really kind of being frowned upon. Actually, not kind of, they are being frowned upon unless the induction is after 39 weeks. If it's something that if it's a delivery that needs to be done prior to 39 weeks, then your physician needs to have accurate documentation that proves there is a concern for the fetus well-being. So maybe you have the lady that is preeclamptic and her pressures continue to get high. Well, we know that if we deliver the baby, that's going to alleviate that preeclampsia, because that is specific to the human species and to the pregnant human species. So ending the pregnancy or finishing the pregnancy is going to be beneficial. So really, all inductions we want to see done at 39 weeks or later if there is no indication for that. The reason being is that we do, with evidence-based research and practice that is out there, there is a higher increased significance of cesarean birth. And we know from discussing in class that the baby's brain develops in the last 6 weeks of gestation. So we want to make sure that physicians are paying attention to that. So the induction method is going to be chosen by the Bishop score, which is completed by the physician. And when you're talking about the Bishop score, what that is specifically looking at is looking at the favorability of her cervix. So is she starting to dilate? Is it soft? Is it posterior, anterior? What is the position of it? Is it midline? So when you're talking the Bishop score, look at table 19.2, and that will give you more information about that. This is just a handout that should be, actually, hopefully most physician offices are using these, and truly it's just to get information out there. And if you look at these pictures and you look at the difference between these two babies' brains, what you'll see is that at 35 weeks we don't have a lot of development, but if we progress to 40 weeks we have much more development of the fetus's brain. And then we also know that during that last month, what we're going to see is that the baby also lays down brown fat stores, which are going to be really important once delivery occurs. So our cervical ripening agents, with chemical, we have a couple of meds listed here: Cytotec, Cervidil. Mechanical, we can use balloon catheters. We can use the Lamera or Lamisil. Amniotic membrane stripping or sweeping. And then physical, things that we could encourage our mom and dad: sexual intercourse, nipple stimulation, and walking. Walking. Other things that you may hear of, kind of old wives' tales, blue cosh or castor oil for contractions, because truly what that does is it causes her to have severe diarrhea, and sometimes that will be enough to aggravate the cervix. Acupuncture and acupressure are also utilized as far as some alternative methods. When you're thinking about the chemical means, both of them, Cytotec and Cervidil, require continuous fetal monitoring. Cytotec is going to be a tablet that is inserted vaginally, and the Cervidil is going to be more of a tampon-looking device, and both of those will be placed by the physician. So it's important to get a good baseline fetal reading prior to the administration of these meds, and then watching for uterine contraction, watching for hypersystole, those types of things. This information is found around page 505 of your textbook if you'd like to do some more reading. With amniotomy, that is just artificial rupture of membranes, and we can use this to induce, augment labor, and it should never be done by a nurse. So our role in artificial rupture of membranes is going to be handing off sterile equipment. The woman has to be at least 1 to, if not 2 centimeters dilated to allow space for the amnio hook to be placed. And what they're going to do is just basically give a little tug on the membranes, and then she should have a gush of fluid. There is a procedure box, 19.9, page 506 of your text, that does kind of just explain it a little more in depth. If we're looking at oxytocin, again, this can be used to induce or augment labor. It is a high alert medication, so it does require 2 nurses checking it. What it can do is cause tachycystole, which will lead to fetal distress and then potentially uterine rupture. So mom always has to be on the fetal monitor. She can get up and go to the restroom, but otherwise she should remain on the monitor. With induction, we can increase it every 30 to 45 minutes, and with augmentation, it's going to be about every 45 minutes and only by 1 milliunit instead of 2 to 3 with the other methods. So refer to policy and procedures at your institution.